Thanks, Steve. Hello, everybody. It's a real pleasure to be here, so thank you for having me. I'm going to talk to you about human factors and that dreaded word, human error. Well, what is this all about? Well, it's about considering the user at the heart of everything you do, considering the person, the task they've got, the environment they're working in, and the equipment that we're giving them to ensure that, like in this well-intended example, we don't end up with the law of unintended consequences that Steve so well put before. And when we put it into the hands of the user, it does completely the opposite of what we intended. Good intentions, but doesn't necessarily do what we wanted. So we need to consider how something's used, where it's used, who it's used by, etc., etc. But we haven't got a lot of time to go through this, and there's a lot of principles, so I'd like you to help me now. If you could all get to your app, your Patient Safety Congress app, to the live Q&A section part, I would like you to help me out with something. And I need you to listen and follow these rules very carefully if you can, please. I would like you to not speak for the next minute or two, not motion to your friends and look for their advice. All I would like you to do is look at the screen, and then as soon as you can, because we don't have much time, I would like you to do a simple counting task for me. I'd like you to tell me how many Fs for Foxtrot, the letter F you see. Are we all happy with that? Okay, quickly as you can, please, and please only have one go. Please only have one attempt. Do it as quickly as you can, please. I have no idea how quickly these things are coming in, but if you can do it as soon as you can, that would be wonderful. I'll give you maybe 20 seconds. Don't double-check, recheck, etc. If you can just have a go. Can people put their hand up if they've had a go? Okay, that's probably enough because we haven't got a lot of time. So if we want to flip to the results, whoever's going to flip to the results and hold it there, can anyone do that for me? Don't know where my technician is. Is that okay for us to flick to the Slido results? I don't know who I'm talking to. Are they coming up? Wonderful. Okay, perfect. We have let's not change it now, guys. We have a normal distribution there. We have many of you around 3, a couple of you down at 2, a small percentage up at 6, and if we had those numbers in order, then we'd have a nice normal distribution, which means you are a normally distributed population, which is fantastic. If we can go back to the slide now, that would be wonderful. The answer is, of course, 6. There are 2 in finished files, there's 1 in scientific, and there's 3 in OVS. And the reason I like to do this is because it's human factors in a nutshell, okay? I've given you a task, you have an interface, you have a performance shaping factor of time pressure, but most importantly, you have a task which on face value appears easy, but actually is extremely difficult. We don't count letters, we don't read words, we read strings of partial words until they make sense. But the important thing about this is to understand when we give someone a task whether what we want to achieve is achievable or not, or whether we're just setting someone up to fail. So how do we reduce errors and their consequences? So we do it by understanding the task and the person's role within it. That's when we can really work out what the performance shaping factors are and help design a system that helps people operate reliably. We can do this with simple models. We obviously don't have a lot of time to theory today, but I'd like to go through a few principles with you and a few just examples from real life. So the very simplest way we can break this down really is action versus intent. Now, some of you may know these principles, some of you may not. But if we look simply at errors of action versus errors of intent, there's a huge difference between how we deal with those and how they arise. An error of action is where you know what you want to do, but you don't do it as intended. Either by an error of omission, where you miss out a step, maybe you get distracted and come back to a task, or you do something wrong. You know what you meant to do, but you carry out the task incorrectly, maybe because of an interface design trap. Whereas an error of intent is something that we do where we choose the wrong action and do it correctly, but we've chosen the wrong action. So we've not made any errors in the task, but we've chosen the wrong task to do. So why is this important? It's important because we need to know why. Just like Steve pointed out to this morning, we have the what at the top, but we need to know why things are happening and what people are doing underneath. Just as a straw poll, anybody ever been in a car when someone's put the wrong fuel in or put the wrong fuel in themselves or know somebody who has? Show of hands, there's cards up. Yeah, exactly, lots and lots of people. No, it doesn't mean that person is stupid. We have things like diesel pumps with unleaded color coding on, so these errors are likely and inevitable almost, given the number of times we do this task. But the important thing here is we need to know why we make a mistake to know what we need to do about it. We can make that mistake for two reasons. First off, we can know what fuel we want and we can pick up the wrong hose. Now, designing that out, obviously we can't design it out completely at the moment, but helping to prevent that error, we can do by revealing that we've made that mistake. We can do better color coding on the hoses. You'll maybe notice now that there's lots of pumps which tell you what you've selected. That will be a really good way of revealing that error because you know what you want, you just got it wrong. If I mean to pick up diesel and I've picked up unleaded and it tells me I have, it will reveal that error. But I can also make that mistake, which happened in my case. My in-laws did this, filled my car up and put the wrong fuel in. They made the mistake for a different reason. They had an error of intent. They thought the car was unleaded, so picked up the unleaded pump. So having a well-designed unleaded hose wouldn't help that. It would just reinforce that you were doing the right thing. So the point with this is, unless we can design something out completely, we need to know why somebody has made a mistake to know what we do to help not make that mistake. The same observable error, exactly the same observable error, can happen for more than one reason, and therefore may need more than one solution. We can also then get more deep into thinking about behavior modes and how people operate on a daily basis, and whether that person is in what we would call a skill-based mode of operation, where you do things routinely, regularly, simple tasks which we call upon with almost little cognitive effort, or we're in a situation where we have done something before, this thing, but we don't do it so often, or it's more complex, so we then are selecting rules, we're implementing plans, etc., and we will make very different mistakes and errors depending on which mode of operation we are in. So to take a very specific example of a skill-based behavior, I should have got these out before, you have to excuse me. If we look at something we might do routinely, such as an auto-injector, and I might normally use something that common practice has a needle cap on it. I also have a safety, and I might inject. It's only a trainer. So if I do that thousands of times and take that needle cap off and then switch that for another device which is similar but slightly different, but it's not different enough that it doesn't drop me into a rule-based behavior where I notice the difference, and I still pull something off, and there's only one thing to pull off, which in an injectable device would normally be on the needle, then my mental model could then be, I've taken the needle cap off, I inject, but I've injected into my thumb, not into my thigh. And this is a good example of something that does happen in reality. It doesn't mean either of these devices are bad, it just means we need to understand how someone is operating to know the sorts of mistakes they will make and how to help them. And just some examples from real life in terms of the things we do and why we do them.
We need to be investing in skills, investing in our young people. And, strong message here, not cutting student numbers.
So Jeremy there just read out his stage instruction, which led to much comedy in the hall. However, when you look at this, when you start to look at the screen prompter coding, what you have is one coding to do two different things. Capitals means either capitalize words that you're going to say but want to emphasize, or give yourself stage directions. So even for an experienced person, just the same as in a medical practice, if you have a small thing that can flip you from what you're normally expecting, this can lead to errors even with a very experienced person. Another example just from general life. This is a regular occurrence in tanker offloading, because tankers are designed to prevent explosions, not implosions. Just like many errors in healthcare, this can happen as a result of a single missed step. Errors of omission, missed steps, are the most common form of errors that you'll ever experience just because of the nature of tasks. And whilst this isn't protected against, it's going to happen with reasonable regularity, just like it will in healthcare. So we've looked at a few general errors there and general behaviors, but it's no different in healthcare. We have to understand what the action is that we're doing, the sorts of errors that we could make. And if that's an error of omission, just like the tanker imploding, that could be very similar to failing to remove a guide wire, for example. Or doing something wrong, an error of commission, could be injecting into an arterial line when we're not supposed to do that, obviously. Now, these things will have some measures in place, checks and balances, but we won't be able to do, we will always have those errors occurring where they can occur. Doesn't mean we shouldn't try to reduce them. However, what I think sometimes we miss is that we are more reliable than we think, and we have to be aware of where we're starting from. So our never events data generally takes us around 3 times 10 to the minus 5, which is 1 never event for every 30-odd thousand operations. This is significantly more than I could ever claim in a safety case I write for a nuclear power station or an oil and gas facility. I would be limited to 1 in 10,000 in all cases for a single team making a mistake. So we are already running at a reasonably high reliability rate. In fact, a very high reliability rate, given all of the factors we're talking about. If we zoom in a little on something specific, which Marianne is going to talk about a little bit later, I think, if we look at failing to remove guide wires, we actually run at 13 in every 25,000, which is 1 in 2,000 operations. Again, this is more reliable than I could ever claim in a safety case. It doesn't mean we shouldn't try and improve it, but it does mean we have to be aware of the limitations of any procedural improvements or task improvements that don't design that error out. So it's important we need to remember that we can't remove errors. We can reduce them, and we can design them out and then remove them, but we can't remove them where they can happen. If it's possible to forget, people will forget. If it's possible to get it wrong, people will get it wrong. Getting upset and people thinking people shouldn't do it won't help us. And adding another check to an already significant procedural arrangement won't help us either much. It might spot a few, but it's not going to remove that error. So whilst we need to reduce the opportunity for error, increase the opportunity for error recovery, reduce the consequences of error, we always need to be aware of where we are already in that system and know the benefits we can get, but also be aware of how much we're likely to change something, which hopefully will lead nicely on to Marianne's, because she's talking about designing out human errors, which is a really interesting area. As an example, however, of things that are significant error traps, it doesn't mean we shouldn't try and design them out by the design of the task. 14 very helpful people, if you put your hands up if you helped me before, would you mind, please? 14 very helpful people did a small formative study with me before. I'd usually want 8 with a formative, but 7's not too bad. And I gave them a task, an error transcription task with a not great view and just a blank canvas. And then I gave them an error transcription task with a good view and an error recovery mechanism, which is 8 boxes to put the characters in. And we went from 2 out of 7 success with the first one, because we have an error trap of 2 V's next to each other, to 6 out of 7 success with the latter option. So we went from about a 30% to an 80% reliability with a simple error recovery mechanism. Okay? So it is worth looking at these things where you have error traps in your system, and they can significantly help remove those things that will trip us up each step along the way. Sorry. So what would I like you to take? I was told it was important for us to take things away. So if nothing else, I would like everybody to be able to go away today, maybe to think about, we need to understand why someone does something, why someone makes a mistake, not just what they've done, in order to help to prevent that happening again. We can't just look at what happened. But we also need to be very realistic about the impact of our improvements. An additional procedural check won't remove an error. It might help a bit, but it might not help very much. And that might be where we have to then look at designing something out if the consequences are significant. But if we understand the task and we understand the person's role within it, we can identify significant error traps that might make us more unreliable than we would normally want and put basic improvements in place, just like the error transcription exercise that I did before. And importantly, and Steve touched on this before, when we look at something that's happened, an error, we have the gift of hindsight. And it's really important not to, but really easy to invent 2 mythical options of right and wrong. This is what someone did, this is what they should have done. And they didn't do it, why didn't they do it? And we can invent this dual path of right and wrong, or correct and error. And we need to remember that that wasn't the case for the person doing the task. They were just doing the task with the equipment and the systems and the training they had at the time and chose the option that seemed right. We need to remember that when we're thinking about things that have happened. Okay, that's me. Thank you.
That was an excellent presentation, Richard, as I knew that it would be. We're going to just suspend questions if you keep them coming on Slido for the Q&A session afterwards. And next I'm going to introduce Marianne Mariaselvam, did I get your name right, hopefully, who is a clinical research fellow at Queen Elizabeth Hospital, King's Lynn. And she's going to take us through the next 15 minutes following on from Richard's presentation. So thank you, Marianne.
Thank you very much. So, yes, I'm Marianne Mariaselvam. I'm a medical doctor working at the Queen Elizabeth Hospital in King's Lynn. And I'm going to be talking about error prevention and implementation and kind of look at kind of show you the things that I've been doing and how, kind of a how-to guide, hopefully. So, just to say, this is one of our other innovations. This is a speaker feedback per delegate slide thing. So, if you would like my slides, you can go to Talk Hub and you can get them. But if you could give me feedback, that would be fantastic because all speakers love feedback, and so it would be really, really great if you could do that. And I'll tell you how to do it at the end. So I'm going to start off by talking about rare, serious, adverse, and never events. And some of the mechanisms that we have to prevent these types of errors are things like education and training, checklists, reminders and warnings, and punishment, which unfortunately still happens. But the question is, well, do they work? Well, so this is the last 10 years' worth of data from NHS England. So it's taken from data extracted from the MPSA and NRLS. And it's clear that despite the preventative mechanisms that we've been using, the actual reported number of never events are actually increasing. And I want to explain why I think this is. I think it's because it's a reliance on things like education and training, checklists and reminders and warnings and punishment. And whilst the first three are laudable, they don't always necessarily work in the context of never events. And I want to explain why. So let's go through them individually. So the first one is education and training. And an example of this is the pre-flight safety check that you get when you get onto a plane. So every time you get a verbal and visual demonstration and a written safety check. And what they're doing is giving you 34 discrete pieces of information, of safety information. And this is effectively remember what to do in all of these situations, just in case they happen. But for a rare event, this actually has quite a limited effect. And you saw this on the Southwest airline flight during a cabin decompression, where passengers accidentally put their oxygen mask just on their mouth instead of on their nose and mouth. And because they're breathing through their noses, they're not necessarily getting the benefit. But what happened? Well, this is what happened. They blamed the passengers. And the message that they're giving out actually is, I'm going to tell you how to do this once, and in the rare instance it happens, I expect you to do it perfectly without making a mistake. And you see from the last slide, it just doesn't work. But what you could do is an engineered solution. So the clinicians in the audience will know this is a Hudson mask, and it has a visual, and it has tactile, and it's ergonomically designed to go over the nose and mouth. And if it's dropped in the correct orientation, passengers know just to take it and put it straight onto their nose and mouth. So you could design this error out very easily. So what about checklists? Well, in some circumstances, checklists are really effective, but I don't think they're effective in all of them. So these are two different types of checklists. One's on the WHO checklist, which is very familiar, and then the other one is one for inserting central venous catheters. So the WHO checklist is great because it's there to ensure that before the start of the procedure, everything is all set up correctly, so you know exactly what you're supposed to be doing. But this checklist for inserting central lines, this is a proposed one from a hospital in the US. And it's for inserting central lines and preventing retained guide wires. And for non-clinicians in the audience, inserting a central line is a time-sensitive procedure. And what they're suggesting is a tick box for every single step of the procedure, including the red thing that I've circled there, which is remember to remove the guide wire. And I think an example of this is the start of a Formula One race. So before the start of the Formula One race, you have a checklist to make sure that everything is working absolutely perfectly, and you've got the time to do that. And that's just like a WHO check. But during the race, when you're going round the bend to the first corner, it's impractical and frankly quite dangerous to stop off and look at a checklist to make sure you're going round the bend appropriately. What you need is skills and an engineering to get you through the race. So what about clinical practice? Well, when you're doing a procedure, you don't stop multiple times in order to check to make sure you're doing all the steps correctly. And as a clinician, it's ridiculous to do this contemporaneously, and because it just incurs delays, and all you do is increase the risk. So actually, what this checklist is saying, especially the point of I've removed the guide wire, it only gets ticked off after the procedure is completed, when you do the paperwork, by which time the error has been made about 10 minutes ago. And after a while, it's just paperwork. You're doing it because we're being audited. So let's look at reminders and warnings. So we're going back to airlines, and this is the inside of a toilet door on an aeroplane. And there are multiple reminders about not smoking and don't use your phone when you go inside the toilet. But there is a problem with people that don't always lock the door when they go to the toilet. And what you could do is you could put lots of signs to say, make sure you lock the door. It's really, really important that you lock the door because it could be really quite embarrassing for you. But experience tells us that people don't necessarily see these signs. They don't read it or they get it wrong. So what can you do? There's a really simple solution that you can do. And what the airlines have done is that in order to go to the loo to turn the light on, you've got to lock the door. And because most people don't go to the loo in the dark, they automatically lock the door. So it's a really good engineered solution to quite a rare event. And this, I think, is a really perfect example. These trapdoors are all over downtown LA with big signs saying, don't walk on them, warning, door may open suddenly. And it's just like a never event, because when it's a rare error, people just stop noticing. And punishment and blame, I put this in because it's sad, because it still happens. And it's actually the easiest thing to do. It's really easy to punish people and say, it's your fault, that's great, we don't have to do anything. But it doesn't solve the problem. It doesn't stop people doing it again and again. So I think in terms of, again, I just wanted to say, they're laudable, and it's really important to try to prevent this. But in terms of never events, they don't necessarily always work. And for a rare error, it's really important that if you introduce complexity or make the procedure more difficult, what you do is you increase the error rate. So when you're designing out things like never events and rare errors, you must not disrupt the clinical workflow. And ideally, what you really want to do is facilitate it. And so what I thought I'd do is take you through an example of this with some of the devices that we've designed. And this is for central venous catheters, so all the steps that you need to do to put a central line in, right from getting the equipment ready to securing it in place, to doing the paperwork, to doing a final chest X-ray. And you can see that because of all these steps, it's really impractical to stop to kind of tick off a checklist every time that you're doing it. So I've looked at the last 10 years of data from NHS England on retained guide wires for this procedure. And you can see that 22% of them are discovered actually just when the paperwork's been signed. Only 23% are discovered on the first chest X-ray. And the vast majority, 55%, are actually discovered after the first chest X-ray, as in on a subsequent investigation or a subsequent check of the central line. So this is after it's being used. So filling out a checklist at the end of the procedure doesn't necessarily always help. And when you're looking at redesigning these systems, so some people say, well, just change the guide wire. You can adapt it and change it and do something with it so that you can, remind people to always remember to remove it. But these are all the points in the central line procedure that you need to use the guide wire. And if you change the guide wire, what you end up doing is increasing errors into every single one of these points. So you've got to really think about the clinical procedure and how it can how your change might negatively affect what the clinical procedure that you're doing. So what we decided was we wanted to introduce a solution which prevents the error, but at the correct point in the procedure. And this is where the error happens, is there on the start. And this is our solution. It's called the WireSafe. And effectively what this is you take all the equipment that you would normally need to use after you would normally remove the guide wire. So that's your suture holder, counter-traction forceps, dressing, a pair of scissors, and you take all of that equipment and you put it inside a locked box. And that goes on your central line trolley, so it's all sterile, it's all there for you as part of your normal equipment. But the only way to access that is using the guide wire to open the box. So effectively, it forces the clinician to remember to remove the guide wire because they can't complete the procedure without it. And in terms of implementation, particularly for rare errors, you've got to have something that's really simple and easy to use. So it shouldn't increase the cognitive load. It's got to be intuitive with very little, and hopefully, if no training, if possible. It really should be compatible with current equipment so it doesn't disrupt the workflow. And it should work with every procedure. And that's ideally how we design the central line. The WireSafe is because it can be used with any central line procedure. It can be used with any current equipment, and it's the current equipment, not a new system change or new equipment that you have to add in. And it can be used internationally because it's the same procedure that happens all over the world. And it also prevents the harm and protects staff from making the mistake. We've actually used over 1,000 in our hospital, and we've had no untoward effects. The feedback's been that it's been really good. It makes the procedure faster, and it's actually easier as well. So we've had really fantastic feedback from our hospital, and we've got a few others actually now that's using it in the NHS. So here's another example of one that I wanted to talk about, to kind of show you that it is actually possible if you start thinking about how you could do this. So in an intensive care unit, there are some patients that will need something called a heat and moisture exchanger. So on A, you can see the round disc at the top, right at the end of the tubing, and that's called the heat and moisture exchanger. And what that does is to humidify the air that's delivered to a patient when they're on a ventilator. But some people will have configuration B, which is a heated humidifier. So the A is a heat and moisture exchanger, and B is a heated humidifier. And that whole system is a heated humidifier as a B. So accidentally, sometimes what happens is the two get used together, and that's on C there, where you see the little green thing at the end on both systems. And if they're accidentally and inappropriately used together, you can have a critical airway incident. And NHS England sent out an alert saying, please make sure you don't make this error and make sure you don't use these two devices together. But what we thought was we could redesign the system. So what we took was the same heat and moisture exchanger, and which works exactly the same as any other normal heat and moisture exchanger, so there's no change of practice at all. But if it's incorrectly used with a heated humidifier, it changes color and it warns. So it only comes into place when the error happens, which is really important for a rare error. You don't want to give people alert fatigue. So this is another one. So accidental injection to the arterial line. So when you're using an arterial line, you use it to very accurately measure blood pressure and to take blood samples. But you never want to give medication into the arterial line. So really easy concept. We designed an arterial connector that has a one-way valve in it. It means that you can always take the blood sample, but you can't inject. And again, it can be used on any arterial giving set. So it solves a problem, it protects patients, and it's universally compatible with any giving set, which makes it really easy to implement. And this final one, so this is a glucose sampling error. So this was an alert that was, again, came out from NHS England. And for those of you that haven't heard of this error, it's when you incorrectly use glucose solution instead of normal saline on an arterial line. And what that happens, it leads to sampling errors and inappropriate administration of insulin, which has resulted in some deaths across the NHS. So what we decided to do was actually redesign the equipment that you need to take the blood sample. So effectively, you take all the equipment that you need to take the blood sample, so all your syringes, your swabs, and your wipes, and you take all of that and put it inside a really convenient sampling kit there. And then, but the engineered solution is one of the syringes. So the waste syringe that you would normally use in your when you take a sample, if there's glucose in that flush, so that if the glucose in the arterial giving set, when you take the sample, it turns the syringe a brilliant blue. So that rare time that it happens, it immediately alerts the clinician, and they go, "Oh, this is something really dramatic. I've got to do something. Something's going on, and I've got to do something about it." So in terms of rare errors, I hope I've shown you examples of what we've done and how we've done it. And I think it's really important that you understand the error and really importantly, the clinical context in which it happens. And I hope that I've kind of shown you that engineered solutions are sometimes the way to go, and quite a lot of the time the way to go, but you've got to think of a solution that's easy to use, that works with the current workflow, and is really compatible with the current equipment. Thank you very much. And if you do want the slides, they're on, you just go to talkhub.org, and if you put in patient safety, you can get the slides, and hopefully you can give me some feedback as well. That would be great. Thank you very much.
Thank you, Marianne, for that wonderful presentation, which dovetailed beautifully with Richard's presentation on human factors engineering and making it easy for people to do the right thing that they intend to do, and hard for people to do the wrong thing, and very hard to do a disastrous thing, as we saw with the tanker implosion there. If we can have the Slido, please. And while that's just coming up, I'll just ask a question or two of my own. Richard, first of all, what's been some of your involvement in, from a patient safety point of view, what's been some of your involvement in designing to make it easier for people to do the right thing as a human factors engineer, as a designer?
Mainly in the development of medical devices and the design, development and formative testing with end users, such that we put the device or the task that device is used for in the context of representative end users within a representative environment with representative training and skills and experience, etc. And any physical, if it's, for example, patients delivering their own medication at home, ensuring that user representation is properly represented as well. So mostly for me in the formative development design, such that you get the reality of how something will be used, and then influencing the design such that when you finally do some form of validation testing, you're confident that that equipment can be used as intended by the people who are intended to use it. That sort of work.
Thank you. We've got some questions through. I'll read the top one first. Human factors is a science and we are all essentially amateurs. How do we implement it from scratch in healthcare? Marianne, would you like to, because you're a clinician who's using human factors engineering approach, so you're the best person of the three of us to talk about this, I feel.
So, yeah, I think it's really difficult, and I think human factors is so important. I think it's such a big part of improving safety in healthcare, and I think fundamentally we actually need to be taught how to do it. I think it's really, it would be great if that was part of mandatory training. For example, we have to do it every single year. Why can't we have a session on human factors? I think it's, I think it's silly that everyone should have to kind of go, well, I'll go and read up a little bit about it on my own and not really kind of understand it too greatly. So I think, if I was able to do it, I'd initially start with that. And there are lots of human factors programs out there. There's loads of really good talks and books and things like that. And it is, I think it's important that you have this kind of really an understanding. But I think it's also important when you see things that are working really well that other people have done, that you try and implement them as well. So because that's a really easy thing to kind of do, to kind of get you starting to think about, actually this. So say for example, it doesn't have to be our things, but with the WireSafe, you can implement it and you can go, actually, this improves the workflow. I can see how that works. Okay, well, what are all the other things that are available? So you don't, it doesn't necessarily have to be doing it from scratch or by yourself.
Yeah. Okay, thank you. We have another question that's popping up there. How can we help organisations understand the importance of why things happen, invest in the benefits of doing so? So, Richard, as a consultant, I'm guessing you've had to sell your trade multiple times. And what's your elevator pitch?
I mean, it's very similar to some of the discussions after your session this morning, Steve, I think, and it really is about putting the skills and the skills, the personnel resource and the time and the money behind it to be able to get that message across. And I don't know, I think you said this morning there is no simple answer other than doing it right. I think it's a really difficult question to answer, in the sense that I think it does come down to influencing the organisation from the inside, and these messages coming through in the design and development practices of whether you're designing a procedure or a piece of equipment, you know, and influence it essentially from the process, the ground up from a process perspective.
Yes.
And it's a difficult question to answer without the right resources, I think.
Marianne, what's your perspective? Because you're a clinician. So, as a clinician, what would you say is your elevator pitch for selling the kind of thing that you've talked to us about?
So I think it's about getting the culture right in the hospitals, and doing a little trap like I've done is an easy thing. I'd say it's an easier thing than getting the culture right, because that's a really, really hard thing to do. But if you have a culture in a hospital where it's we're kind of positively saying we're looking at safety, we're trying to prevent error, we're supporting our staff to do this, then that really comes from a management level, and it comes from all the kind of senior clinicians, and it should be a message that filters down appropriately across the hospital and across across all hospitals in the country, and then you can kind of see the benefits, and you can have the long-term investments. I think because unfortunately we're in a financially cash-strapped institution, so the kind of benefits of patient safety are kind of long-term. They're not the kind of quick wins that you get, really. So I think that's the difficulty that we have.
Perhaps another selling point is because safety can be quite hard to sell, because you're selling a dynamic non-event in a sense. So we have to look for other things, maybe such as looking at quality and looking at money saved, reduction in waste, for instance, reduction in retraining, and perhaps these kinds of things as well. Yeah. We have another question popped up to the top. How would you set up a human factors team within a healthcare setting? So how did the RSSB, which is the Rail Safety Standards Board, for example, start out? So
I think you could probably answer that better than me.
Well, I mean, I've never set up, I've been in many human factors teams, but essentially what I observe is that it's very important who is the first people that you get. So NHS organisations, hospitals may not be particularly friendly for people who are like me. Well, I'm not a clinician, I'm not a doctor or a nurse, so it's not the most friendly place. So the first person you get is quite important, and probably pretty good that they have good cover from the culture a little, so they'll need good internal allies, I guess, and it needs to be someone with a fair bit of experience who's comfortable working at the most senior levels as well as with the staff, and ideally not to be working on their own. Very few professions work on their own, and so you shouldn't expect to go in and be the only person in the hospital.
You would
doing
need
that.
influence of the system, wouldn't you? You'd have to be able to influence the system.
Yeah.
Having someone at a level that can't necessarily put mechanisms or systems or training in place is going to be on a hiding to nothing, essentially.
I mean, another thing that's probably worth mentioning is to have advocates who are able to speak for the importance of this, such as Martin Bromley, who has done, possibly more for human factors in healthcare than certainly anybody that I know, and he's come from a pilot background, but he's been able to articulate the benefits of making it easy to do the right thing and hard to do the wrong thing, and organising the relationships and the expertise from diverse sources that you need in order to achieve that aim. I think we've got time for another question. In moving to a blame-free culture, or we might say a just culture, how do we counter the complacency that comes with increasingly process and policy-driven practice? Marianne, I'm going to rely on you to answer this question or to respond to this question.
So I think when you have an error, it's really easy to write a policy that says don't do it, and it's quite frankly, I think it's silly to do that. I don't think they help. I think they just encourage a blame culture. And I think if you do have these mistakes, it's more important to think about, like I said, the error and why the error happens and the clinical context in which you're doing these procedures. And that's a much more valuable use of time than writing a policy that no one is, quite frankly, going to read. And I think it's also really important in terms of, particularly with these kind of policies and things, is that as a junior doctor, we rotate around lots of hospitals around the region, and just because one policy in one hospital says that don't do this, it doesn't mean that the error isn't happening in every other hospital with all the other different types of equipment and different changes and things like that. So just writing a policy for the sake of a policy doesn't help, and like I said, in the end it just becomes paperwork.
Okay, well that's brought us perfectly to time, and I don't want to delay the changeover, but I hope you've enjoyed this session as much as I have, and please a final applause before you go off to your next session for Richard and Mary Ann. Thank you.